Is it all right now?
Yes, doctor, now it's clear.
All right. So now we start with the second part of benign prostatic hyperplasia. And this is the treatment of BPH. All right. So we'll start with this management algorithm for BPH. We first confirm that we have diagnosed BPH. So we take history. We do a physical examination. We do a digital rectal examination. And we do those laboratory evaluations and ultrasounds if necessary. All right. So after differential diagnosis, it depends whether we have diagnosed BPH or not. If we do not find BPH, then we will consider referral. But if BPH is there, then we will calculate an international prostatism symptom score. That is one of the ways of going forward with the treatment. So we can have three types of scores. If it is less than 7, then the disease is mild. If the score is between 8 and 19, then the disease is moderate, and above 20, which is 20 to 35, the symptoms are severe. So in mild cases, we just wait and watch. We don't do anything. We observe for changes of worsening of symptoms that might take many, many years. In case of moderate symptoms, we give pharmacological therapy, and depending upon the quality of life, we can either do medical or pharmacologic therapy, or we can refer the patient to the urologist for surgery, all right, or whatever intervention he wants to do. So calculation of international prostatism symptom score, there is a calculator that is given on the internet, and this is the link for that. And there are a number of questions, about 7 questions that the person has to answer. So you will give this questionnaire to your patient, and he will click on the radio buttons depending upon whatever symptoms he is experiencing. So 7 questions, and at the end, it will give you a score, and it will tell you whether the symptoms are mild, and it will depend on your clinical judgment as well. Okay, so this is one of the ways that would guide your therapy. So mild symptoms are usually, mild or mild disease. You can say the disease severity. If it is mild, then the score is less than 7 or is equal to 7. The person will be asymptomatic, and the peak urinary flow rate will be less than 10 ml. Normal is usually more than 10 ml per second. Post-void residual urine will be more than 25 to 30 ml, which is normal. And increased BUN and serum creatinine may be there, okay? It may or may not be there. In moderate disease, all of the above signs plus obstructive voiding symptoms that I've given you previously, and irritative voiding symptoms, okay, which are signs of detrusor instability. And we said that they are mostly neurological in nature. And these are sort of due to the increase in the volume of the prostate gland, the obstructive symptoms. Then severe disease, we have all of these symptoms, plus we have one or more complications of the BPH, like trabeculations in the bladder, or hydronephrosis, or other complications like diverticulum in the bladder. So these types of things can be there. So therapeutic options for BPH are watchful waiting, drug therapy that includes alpha-adrenergic alpha-1 blockers, 5-alpha reductase inhibitors, and there are some other drugs as well. Then we have interventional therapy, which is surgical therapy. And we have this well-known transurethral resection of the prostate, which is known as TURP, most commonly done for patients with moderate to severe LUTS and those who have developed acute urinary retention or other complications, all right? Metabolic syndrome, there is a high prevalence, and that increases the severity of BPH. So there should be strict glycemic control, and healthy lifestyle measures should be taken. That will postpone the progression of the symptoms. Most patients with BPH have milder LUTS and therefore are initially treated with medical therapy. The American Urological Association guidelines suggests several minimally invasive interventions. These are surgical procedures that have been developed recently and that are alternatives to transurethral resection of the prostate, the TURP. Alpha blockers, smooth muscle contraction in the prostate, stroma, urethra, and bladder neck is mediated by alpha-1 receptors that is thought to be a significant component of lower urinary tract symptoms. So again, alpha receptors highly concentrated in the bladder neck or bladder outlet, and they are distributed all over the prostate gland, including the capsule and the region surrounding the urethra. Therefore, alpha blockers decrease resistance by relaxing the smooth muscle, thus allowing easier passage of urine. And when you give alpha blockers, there is an approximately 4 to 6 point improvement in the IPSS scores that we calculated previously. However, alpha blockers do not reduce the overall long-term risk for acute urinary retention or need for surgery because they do not decrease the size of the prostate. They relieve the symptoms. They will cause relaxation of the smooth muscle, but they will not cause a decrease in the volume of the prostate gland. And the drugs that we have are short-acting selective alpha-1 blockers, which are prazosin and alfuzosin. Then we have long-acting alpha-1 blockers, which are terazosin and doxazosin, and slow-release formulations of alfuzosin. Then we have selective alpha-1A receptor blockers, okay? Those are tamsulosin and silodosin, right? And silodosin, according to American Urological Association guidelines, do not include recommendations for silodosin due to lack of clinical trials. However, efficacy of silodosin is similar to tamsulosin. Tamsulosin is more commonly used, but it has got certain problems. For example, sexual side effects are higher with silodosin and also with tamsulosin. Retrograde ejaculation is more common. Tamsulosin affects ejaculatory functions and ejaculatory volume, and 35% of patients experience an ejaculation, which means no ejaculation. There could be postural hypotension with tamsulosin. And that could happen with all alpha blockers, all right? Retrograde ejaculation means that the ejaculate or the semen goes into the bladder instead of going out of the body. Intraoperative floppy iris syndrome is one of the complications of using tamsulosin that happens during cataract surgery. There could be meiosis, which means contraction of the muscles of the pupil, and billowing and prolapse of the iris, okay? Now here is tamsulosin. You see the dose over here, 0.4 milligram, and this is the brand name, very well-known brand name, Flomax. And this is the mechanism of action. Normally what happens is that alpha-1 receptors, they cause an increase in the inflow of calcium. So the intracytosolic calcium concentration will increase. Calcium will also be released from sarcoplasmic reticulum. And when you increase the concentration of calcium inside the cell, that would lead to contraction of the smooth muscle. So when you block the alpha-1A receptors with any of the drugs, then this will not happen. There will be a less increase in the calcium concentration inside the cell. So the cell will relax instead of contracting, okay? These are the drugs, alpha-1 antagonist, silodosin is there, different doses have been given over here. You have terazosin, the brand name is there, okay? Different doses or different strengths that you have, 1 milligram, 2 milligram. You have prazosin, 1 milligram, okay? So the doses are given over here. But I will not ask you to memorize the doses if they are not there in your PowerPoint because of copyright reasons. Cardiora or doxazosin is very commonly used in Saudi Arabia. And this is also very useful over there. Okay. Then we go on to 5-alpha reductase inhibitors, which are also known as 5-ARIs. Two 5-alpha reductase inhibitors are approved, which are finasteride and dutasteride. And AUA guidelines advise that men with LUTs, lower urinary tract symptoms, 5-ARIs may help prevent progression of LUTs and reduce the risk of urinary retention. So what we have seen is that urinary retention is a very dangerous thing because of the back pressure into the ureters and in the kidneys. It could damage the kidneys, and it could lead to, it can lead to chronic renal failure or chronic kidney disease. So 5-alpha reductase inhibitors improve LUTs by reducing prostate volume, right? So that's the difference between finasteride, dutasteride, ARIs, and alpha blockers. Alpha blockers do not reduce the prostate volume, whereas these drugs, they do reduce the prostate volume, although they take a longer time. Patients with larger prostates may achieve a greater benefit. Now, maximal reduction in prostate size requires about 6 months of therapy. So one important difference between ARIs is that in the long term, ARIs are better because they reduce the size of the prostate gland, and that may delay the requirement for surgery. But alpha-1 adrenergic blockers, they relieve the symptoms immediately. They act very quickly in relieving the symptoms. So both groups of drugs have their own advantages. Okay. Inhibition of 5-alpha reductase type 2 blocks the conversion of testosterone to dihydrotestosterone, resulting in lower intraprostatic levels of dihydrotestosterone. And I explained that to you in the second slide. This leads to inhibition of prostatic growth, apoptosis, and involution. Dutasteride has an affinity for both type 1 and type 2 5-alpha reductase receptors, but the significance of type 1 receptors is not known. All right. So the bottom line is that 5-alpha reductase inhibitors decrease the level of dihydrotestosterone inside the prostate gland, inside the prostate cells, and that will lead to involution of the prostate gland. Finasteride is also used for hair loss. It increases the scalp hair, but it does not increase the body hair. So here is Proscar, which is finasteride, 5 milligram. This is dutasteride, 0.5 milligram. And there is, some warnings given, if you can read that. Women who are or may potentially be pregnant must not use Proscar or finasteride. They should also not handle crushed or broken tablets of finasteride. Okay. Both finasteride and dutasteride actively reduce dihydrotestosterone levels by more than 80%, and that is good efficacy. And they improve the symptoms, reduce the incidence of urinary retention, and decrease the likelihood of benign prostatic hyperplasia. The adverse effects of both these drugs are sexual dysfunction, which is decreased libido, which is desire to have sex, or erectile dysfunction or ejaculation disorder. This is dutasteride, 5 milligram. Okay, both finasteride and dutasteride may reduce PSA by 80%. PSA. That was dihydrotestosterone, they reduced by 80%, but PSA, they reduced by 50%. And you must keep this in mind, as I'll tell you a little while later, that if you're doing PSA levels for prostate cancer, then you have to take into account the use of these 5-alpha reductase inhibitors. The decrease in PSA is typically maximally achieved when the maximal decrease in the prostate volume is noted, which is 6 months. And this effect must be taken into account when using PSA to screen for prostate cancer. Both drugs are similarly effective in using prostate volume and increasing the urinary flow rate. Pregnant females, as I mentioned in the previous slide, or those who are considering conception should not handle crushed or broken tablets because of the potential for absorption through the skin and subsequent potential risk to a male fetus. Okay. In 2011, FDA advised that prior to initiating therapy, other urological conditions should be ruled out. Okay. And two large randomized controlled trials have found that although there was a decreased incidence of prostate cancer. Now, note this point. When you use these drugs, 5-alpha reductase inhibitors, dutasteride and finasteride, they are protective against prostate cancer, right? So they protect the person against prostate cancer, but the problem is, if the prostate cancer does develop after the use of these drugs, that prostate cancer is more aggressive, okay? But this point is controversial. That is what is written in the last paragraph. Right, so different strengths again of finasteride, different brands, different preparations, different doses, 1 milligram and 5 milligram. And this is an article that was published in New England Journal of Medicine in 2019. In BPH, 5-alpha reductase inhibitors are linked to higher risk of diabetes type 2. And in this study, they studied about 39,000 patients who were prescribed 5-alpha reductase inhibitors, and they had 16,000 controls as well. And what they found was that 5-alpha reductase inhibitors was associated with about 30% increased risk of diabetes relative to tamsulosin, which is a selective alpha-1 adrenergic blocker, okay? Then we have combination therapy. American Urological Association guidelines advise that combination therapy with alpha blocker and 5-alpha reductase inhibitors can be appropriate and effective for patients with lower urinary tract symptoms who have enlarged prostates, okay? Now, as I said, alpha-1 blocker provides rapid relief. 5-alpha reductase inhibitors targets the underlying disease process, and they decrease the likelihood of surgery, or at least they delay the need for surgery, okay? There are fixed dose combinations available, tamsulosin 0.4 milligram and dutasteride 0.5 milligram, and the brand name is Gelin, which I'll show you in this slide. There is one combination of doxazosine and finasteride as well, and this is Gelin, dutasteride and tamsulosin. And again, the same warning has been given on the box, okay? Pregnant women or those who are planning to be pregnant, they should not handle dutasteride and finasteride containing tablets or drugs, okay? Now, phosphodiesterase 5 inhibitors, PDE5 inhibitors. These are the drugs that are used in erectile dysfunction as well. And they have a role in enlarged prostate as well. So PDE5 inhibitors are known to mediate smooth muscle relaxation in lower urinary tract. This is the same mechanism that is used for treating erectile dysfunction, which is relaxation. In that case, it is relaxation of the blood vessel smooth muscle in the corpora cavernosa, and in the prostate, it is the relaxation of the smooth muscle of the prostate gland, okay? The long-acting PDE5 inhibitor, which is tadalafil, the brand name is Cialis, has been shown to be significantly better than placebo, okay, in controlling lower urinary tract symptoms. Tadalafil is approved for treatment of the signs and symptoms. It is used alone, or it could be used in combination with finasteride. So we can use tadalafil 5 milligram plus finasteride 5 milligram orally once daily for 26 weeks or less. Tadalafil is also approved for daily use in patients with both BPH and erectile dysfunction. In patients with BPH who also have erectile dysfunction, alpha-1 blocker dose should be established. Now, just to remind you that vasodilators, when combined with phosphodiesterase inhibitors, are dangerous for those patients who have got ischemic heart disease, all right? So this combination of vasodilators and phosphodiesterase inhibitors contraindicated in patients with ischemic heart disease because that could lead to tachycardia, hypotension, and precipitation of symptoms of angina. The medication used to treat erectile dysfunction should be titrated to the lowest effective dose. If sildenafil, which is Viagra, if sildenafil is used, doses greater than 25 milligrams should not be taken within 4 hours of any alpha blocker. Okay, so tadalafil plus finasteride is a good combination for treatment of BPH, and the doses for both of them is 5 milligrams. Here is a box of Cialis. This is 5 milligrams. It is also available in a 20 milligram strength. Now we go on to anticholinergic drugs. Historically, anticholinergics were discouraged in men with BPS because of the fear of inducing urinary retention, all right, because we have got cholinergic receptors in the bladder wall. So the detrusor muscle contracts when it is stimulated by acetylcholine. So if you give anticholinergic drugs, acetylcholine will be blocked and the bladder will not contract. That could lead to urinary retention. So we can use anticholinergic drugs, but with certain conditions and precautions. So trials in patients with BPH have demonstrated a slight increase in post-void residual urine volume with use of anticholinergic, and that makes sense. However, acute urinary retention rates were low. Importantly, these trials consisted of patients with low baseline post-void residual urine, right? So one of the conditions for giving these drugs is that there should be no post-void urine. It should be within normal units or it should be very low. The American Urological Association BPH guidelines recommend anticholinergic agents for management of lower urinary tract symptoms in persons who do not have elevated post-void retention of urine or post-void residual urine, okay? So this you have to keep in mind. You have to take a baseline post-void residual urine, and then you have to monitor that as you give the therapy. And if it increases, that means it's time to discontinue the drug. Caution is recommended if post-void residual urine is greater than 250 to 300 ml, then these drugs should not be used. And the drugs are oxybutynin and tolterodine. These drugs relieve irritative voiding symptoms, which are due to bladder, including urinary frequency, urgency, and nocturia. You start with lowest effective dose, measure post-void residual urine, and monitor it, okay? Derifenacin and sulifenacin, they are selective for bladder. They do not cross the blood-brain barrier. Consider transdermal, which is a skin patch, okay? Transdermal or extended release formulation of these drugs if systemic anticholinergic effects. What are the systemic? You know, if you block the cholinergic receptors, it can have a lot of systemic effects. It can cause dry mouth, it can cause a dry nose, it can cause tachycardia, it can cause constipation, and it can also cause retention of urine, okay? So you have to be very careful. We have these beta-3 agonists, and the drug is mirabegron. Mirabegron does not have anticholinergic side effects, and it is generally well tolerated, but it is used in only one situation, and that situation is overactive bladder. Basically, this is a drug for overactive bladder, okay, which is a separate condition from BPH, but it could be present with BPH as well. So mirabegron is indicated for treatment of overactive bladder induced by BPH in men receiving tamsulosin therapy, and we give it in combination with tamsulosin because it can lead to poorly controlled hypertension. And it also has the risk of increasing post-void residual urine volume. So you have to continuously measure that. And the non-invasive method is ultrasound. So let's go. Now we go to phytotherapeutic agents. These are not allopathic medicine and very commonly used. But what we do in pharmacy practice or therapeutics is that our practice is based on evidence, right? Right. And if we do not have good evidence, and good evidence means randomized controlled clinical trials. That's where we get the evidence from. And we give recommendations, right? We give class of recommendation. We have class A, class B, class C recommendation. So we will discuss a little just in one slide, and I'll only give you the names of the phytotherapeutic agents. They are natural products, and you will be doing them once again with Dr. Onim. So we do not, at this time, we do not have sufficient clinical trial or sufficient scientific evidence for the use of these drugs, okay? A number of herbal formulations and plant-derived compounds have gained popularity worldwide for management of BPH. Phytotherapeutic agents and dietary supplements are considered emerging therapy by American Urological Association guideline and are not recommended for the treatment of BPH because of lack of evidence, all right? And we get our evidence from clinical trials. There is a general perception of therapeutic healing powers of natural herbs and lack of adverse effects. And that's why it's not that they are not commonly used. They are very commonly used, particularly in Europe. So most of the phytotherapeutic agents are used for the treatment of LUTs secondary to BPH are extracted from roots and seeds or bark or fruits of the plants that are given below. They include saw palmetto, South African star grass roots, African plum tree bark, stinging nettle roots, rye pollen, and pumpkin seeds. Okay, and no clinical trials are available to show their efficacy or guide therapy. The information comes from anecdotal reports, but that does not mean people do report benefits from them, but we cannot include them in the guidelines because whatever we include in the guidelines, we should have evidence for that through clinical trials. So this is saw palmetto. It has got anti-androgenic effects, just like 5-alpha reductase inhibitors. It has got anti-inflammatory effects, and the AUA guidelines did not detect a clinically meaningful effect. Okay, so that's the problem. It is no more effective than placebo, according to American Urological Association. Stinging nettle root may be effective at relieving symptoms, and it might slow down the growth of certain prostate cells, but it does not decrease the size of the prostate gland. Okay. Then African plum tree, it has not been well studied, so no comments on this one. Rice, cereal, okay. The anecdotal accounts are that it does cause significant symptomatic improvement versus placebo, but again, no clinical evidence of that. Pumpkin seeds may reduce urinary urgency and frequency. They increase prostaglandin synthesis. They have anti-inflammatory effects, but their effect on prostate gland or the size of the prostate gland is not known. Okay, so this is what we have done in the treatment. Just a quick recap. We looked at the algorithm for the management. We looked at IPSS scores, and according to that score, we divide the prostate symptoms into mild, moderate, and severe. And based on the prostate symptoms, we decide upon the treatment, whether it should be just watchful waiting or pharmacological therapy or surgery, right? And this is a website that will permit you to calculate the IPSS score, okay? Then we looked at the symptoms in mild, moderate, and severe types of the diseases. Then we discussed the therapeutic option, watchful waiting, drug therapy, or surgical intervention. We discussed the alpha receptors and alpha blockers. Silodosin, tamsulosin. There were so many of them. Their mechanism of action, we discussed 5-alpha reductase inhibitors, and we said that they take about 6 months to reduce the size of the prostate gland. And we said that alpha blockers act rapidly in relieving the symptoms, whereas 5-alpha reductase inhibitors take 6 months to reduce the size. I showed you the drugs. We discussed a little bit about those drugs. And side effects of 5-alpha reductase inhibitors include risk of development of diabetes. We have combination therapy in which we combine alpha-1 blockers and 5-alpha reductase inhibitors. We have certain fixed combinations for that. Then we discussed phosphodiesterase 5 inhibitors, tadalafil particularly, and we said that tadalafil could be combined with finasteride for the treatment of BPH. Then anticholinergic agents, we have to be very careful. We have to continuously monitor the post-void residual urine if we use them. We have 4 of them: oxybutynin, tolteridone, we have got derifenacin and sulifenacin. Then beta-3 agonist mirabegron, and we had these phytotherapeutic agents, which are 5 of them: saw palmetto, stinging nettle root, or pygeum African plum tree, or rye and pumpkin seeds. Okay, so that was all about the second part, and I think we will again take a break, and then we will come back in 15 minutes. All right.